Dr. Rafage from Veterinary. We're going through a brand new journal, JAVMA, February 15, 2015, an oldie but a goodie. We'll see. This is the first article to What's Your Diagnosis? A 3-year-old female spayed mixed breed dog evaluated for chronic weight loss and vomiting for 1 year, episodic diarrhea. The dog was severely cachectic on physical exam. There's different types of cachexia. Cachexia means severe body condition loss, and which is different than sarcopenia. Sarcopenia means muscle loss. So obviously, I would argue probably that all sarcopenia is included in the category of cachexia, but not all cachexia is sarcopenia. So cachexia can be from like cardiac disease, for example. We call it cardiac cachexia. It's not a muscle issue. It's a problem with supplying the cells of your body with the blood flow needed from the cardiovascular system due to cardiac disease, for example. The dog on blood work had leukocytosis. Leukocytosis is an elevated white blood cell count. Remember, there's only a handful of causes of elevated white blood cell count. It's going to be infection, cancer, inflammation, and stress. And it's when you have a leukocytosis on blood work, you want to characterize it by mild, moderate, severe. And also you want to characterize the types of cells, the cell distribution. So this leukocytosis is characterized by neutrophilia and monocytosis. And so when you think about elevated neutrophils and elevated monocytes, you think about a partial stress leukogram. If you had a full stress leukogram, you'd also would see lymphopenia and eosinopenia. The dog also had hypoproteinemia and hypoalbuminemia, so low protein, low albumin. That kind of makes sense every time you have cachexia for any reason. Clearly this dog is having some sort of malabsorptive problem because he's been vomiting for a year, and weight loss is going to have low protein and low albumin. And then hypocholesterolemia, same thing. If you're not ingesting fats appropriately, then you're not going to create cholesterol. Hyperkalemia, so elevated potassium, which that could be spurious too. It also could be probably from muscle destruction or cell destruction, rather, from whatever's causing this disease. Hyperchloremia, so elevated chloride. Not sure really how to explain that. Maybe it's spurious, a lab error. Maybe it's normal for this dog, or maybe it has something to do with the ratio of electrolytes due to chronic weight loss and malabsorption. Maybe it's due to something wrong with the gastric acid production. That could be it too, because he's not really eating. So maybe he's got like increased hypochloric acid, stomach acid production. And then we have here, it says here, total calcium was normal. The phosphorus was mildly decreased. So here are some radiographs. So you have the dog, a 2-view orthogonal abdominal radiograph. You can see the severe weight loss. And then in the area of the stomach, there is a linear mineralized foreign object in the stomach. So on the radiographs, they describe it as a large heterogeneous mineralized structure in the region of the pyloric antrum and gastric body. They did then abdominal ultrasound, and you can see here the ultrasound with the asterisk and the arrow. And the arrow is pointing to a mildly intraluminal hyperechoic heterogeneous gastric content associated with the asterisk, which is a large hyperechoic structure with strong distal shadowing. So ill-defined, irregularly shaped heterogeneous mineralized structure with multiple linear mineral opacities in this gastric body and pyloric antrum. Differential diagnosis for these lesions include gastric wall mineralization or mineralized mass in the right cranial aspect of the perineal cavity. Abdominal ultrasound showed the intraluminal gastric content, large hyperechoic interface with strong distal shadowing as well observed in the stomach. There was gastrointestinal hyperperistalsis and severe mesenteric lymphadenopathy. Lymphadenopathy, really only 3 causes for that: infection, inflammation, or reactive, and neoplasia or cancer. They did an upper gastrointestinal scope and saw discoloration and thickening of the duodenal mucosa and gastric mucosa. They collected biopsies, which found focal severe granulomatous duodenitis with intralesional trematode eggs and diffuse mild lymphoplasmacytic and eosinophilic duodenitis associated with multifocal cryptostension. So that's interesting because in the blood work, the eosinophils were normal. So that's weird that they didn't have a peripheral eosinophilia, Maybe it's due to the chronic nature of this disease. When you have granulomatous disease, it creates basically a walled-off lesion, and perhaps those eosinophils that were infiltrating the lesion were not escaping into the vascular space and therefore not reflected in the blood work. Small to large number of spirochetes were observed in the duodenal and pyloric samples. No evidence of mucosal mineralization or granulomas. They did a fecal saline sedimentation test, and they found medium numbers of Heterobilharzia species, leading to the final diagnosis of gastrointestinal schistosomiasis. They treated the dog with praziquantel and cyanobalamin, and that cured the dog. All right, comment. So, just in case you're wondering, the reason why I have this picture here of a life cycle, here is a dog. There is a Kercharia penetration of the skin of the definitive host, which is the dog. Then these paired adult worms live in blood vessels. They create eggs, lay them by the female, pass them in the host feces, which then in the water, Merachidium hatches from the egg, infects this intermediate host, which is a snail, and then it releases Kercharia by the snail into the water, and then the dog's exposed. And so this is the life cycle of the Heterobilharzia americana. Now in this paper, they didn't specify the species of the worm, but they're diagnosing Heterobilharzia based on the fecal. So pretty cool case. Let's go into the details of this disease. It is usually seen in southeastern United States. Treatment is usually praziquantel or fenbendazole. Infected dogs have adult worms present in the mesenteric veins where oviposition occurs. Eggs migrate through the intestinal wall, induce delayed hypersensitivity reaction and secondary severe granulomatous reaction. Some eggs will also spread hematogenously to the liver or other organs such as lymph nodes, stomach, pancreas, spleen, kidneys, brain, lungs. A severe granulomatous reaction induces tissue alteration and necrosis. Injured or dying cells are not able to maintain normal calcium, leading to increased intracellular calcium and secondary dystrophic mineralization of the affected tissues. Heterobilharzia americana infection and more generally granulomatous disease have also been reported to induce hypercalcemia secondary to hypercalcitrolemia or parathyroid hormone-related protein synthesis. In these instances, when extracellular calcium concentration exceeds the homeostatic capacity of cells and tissues, meaning when the calcium phosphorus concentration product exceeds 60 to 70 mg squared per deciliter squared, soft tissue mineralization can then occur and is termed metastatic mineralization. In contrast to dystrophic mineralization, metastatic calcification is associated with hypercalcemia and is more generalized, although some tissues are more prone. GI tract, kidneys, heart and skeletal muscles, intima of the arteries, ligaments, and tendons. In the case here, the dog was normal calcemic with mild hypophosphatemia, and the calcium phosphorus ratio, or product rather, was not high enough to induce calcium deposition. Therefore, the stomach mineralization in this report was considered to be dystrophic mineralization from severe granulomatous inflammation of the gastric wall and not metastatic mineralization. The mineralization likely affected the submucosal muscularis or serosal layers, considering that the mucosal biopsy samples did not have evidence of mineralization. So scoping biopsies they don't go deep enough for some diseases. So if you went based on scoping and you didn't do the fecal, you wouldn't have found the mineralization because the endoscopic biopsies only sample the mucosa and doesn't sample the serosa muscularis or submucosal layers of the stomach. Faint linear intestinal wall mineralization can be observed on abdominal radiographs, and multiple mineralized irregular foci are often visible ultrasonography within the pancreas and hepatic parenchyma. Additional ultrasound changes in the GI tract have included a thickened intestinal submucosa with multiple hyperechoic submucosal pinpoint foci also present within the muscularis layer. In these reports, most of the eggs were mineralized, surrounded by granulomatous inflammation, and mainly observed within the small intestine submucosa on histologic evaluation, with smaller numbers visible in the mucosa and muscularis layers. So pretty cool case. I wouldn't have thought about an upper GI scope. I probably would have went right to surgery, but that's me as a surgeon. I'm a bit more biased, and it would have been disappointing. I would have done a gastrotomy and not found any foreign body or mass. I would have biopsied the stomach and then small intestines, lymph nodes, probably pancreas, liver, and see what those show. And then I would have probably gotten my answer there, and it would have been full thickness. So I would have seen the worms in the biopsy samples, and I wouldn't have done a fecal. Well, maybe I would have actually. With chronic GI signs, you probably want to do a fecal with your blood work and urine testing. But anyway, I love cases like this. Very cool. And yeah, thanks for supporting the channel. We'll see you in the next one. Bye-bye.